how we operate. Dr. Meyer is professor of otolaryngology here at MUSC, where he also serves as the residency program director and the director of the neuro-otology fellowship program. He completed his medical school training at UIC in Champaign-Urbana, as well as his PhD in the Department of Speech and Hearing Science. He then went on to complete his residency training at Indiana University, followed by a fellowship in neuro-otology at the University of Iowa. Dr. Meyer's research focuses on the question of what makes a good surgeon and how can we better understand the nature of surgeons' movements and use this information to educate and optimize performance in the OR. So thank you so much for joining us today, Dr. Meyer, and we look forward to hearing your talk.
Thanks, Josh. There's Dr. Raymond joining us from Florida. Hi.
Hi.
All right, I've tested this. It's all supposed to work. Let's get to slideshow here. All right, can you guys see that and hear me?
Yep, can see it and hear you.
All right, so how we operate is going to refer to how we as otologists and neurotologists operate. We've got a little bit of funding from MUSC for this, and a few of our students have gotten some funding for doing summer projects through a training grant here. And been working on this a while, a little bit piecemeal. I'm now doing Inspire surgery mostly. And as we've just hired a new sleep surgeon as of today, we will transition back more into neurotology. But this started a long time ago. Lots of students in there who have transitioned into residents, most of them ENT residents, and some of them have gotten funding through this or through the summer research fellowship. And we're starting some collaborations with some folks within MUSC and then outside MUSC. And this is looking at doing some work in this field with computer vision or artificial intelligence in hopes of perhaps making this even turn into an application of some sort. A couple of papers have been published on the research that we've done, and this is really about resident teaching using these methods. And Royal Pipolai, who's one of our students interviewing for an ENT position this year, has a paper coming out soon. So this goes back to education and training and evaluating trainees. And those of us who've been through this or are going through this understand that resident evaluation is mostly subjective. You hear things about good case or good job today or nice hands. I think we're doing better in terms of feedback. We do have milestones. There's a second version of milestones coming out, and Mallory and I worked hard with the neurotology version 2. And there are some things in there in terms of picking skin off the facial nerve or doing a facial recess, those sorts of things. But a lot of the milestones are very generic. There are some objective structured tools, and there are some other things that are being looked at currently. Not terrific. We hope that more objective methods are coming. And for example, artificial intelligence, we hope can be used in this area. A lot of what's been done in otology is looking at what people do in the lab, or taking a complete novice student, having him or her do something and then measure how they do on a cadaver specimen. All good. Hard to harm a cadaver. But in terms of what we are doing, it's not game time, it's not live surgery, it doesn't necessarily matter. A complication on a cadaver doesn't really exist. So this is really taking a different approach. And we're all surgeons, or surgeons in training. So surgical education is important. And we hope and we want to better understand surgical training, what that takes, what that means, and improve it as well. We are also coaches in many ways. And Mallory's done some research in terms of coaching, in terms of measuring what we're actually saying, and then the outcome of that. So important as well. So thinking about education in terms of surgery, well, we have direct patient care. We also have lectures and labs. And we are adult learners by this point in our lives. This is self-directed reading and learning. This is not grade school. This is not high school. Everything's not spoon-fed. And it's hard to do some of the things that we do as surgeons, especially when we're trying to get better at dealing with patients and bleeding and having cases taken away from us. And let me take a look at this. So trying to figure out what to do to train surgeons as well as learning to be a surgeon is complicated. We have subjective and biased feedback. No question, surgeons training surgeons have biases. And sometimes those biases stay with us as educators. Intraoperative challenges. Ear surgery is particularly challenging. Small surgical fields in all of ENT, but especially in the ear. Hard to do multiple surgeon surgeries when it's really a single surgeon case. And what are we actually measuring and what are we looking at? A lot of improvement with surgery is the improvement of the non-dominant hand, and that's typically not focused on by the surgeon, nor is it focused on by the surgical educator. So long way to go to figure out what we're doing, although I think we do a good job, and I think we have, in trying to use objective skills, measurements, and perhaps even AI to improve all of this. Clearly, patient care and safety and outcomes are important. So there are things that are just really not acceptable in terms of problems during cases. So we all train for a long time, 5 years or 7 years, and surgery is as much an apprenticeship model, and you do learn from experience and you do have graduated autonomy. First-year residents are not doing the exact same things in the case that a senior resident is. So here's one example of just thinking about some things that we do. So we've done some preliminary measures here. And for example, let's take Josh as an example, who's a new fellow. And this doesn't necessarily focus on him or a new fellow versus a more senior fellow. But for example, what's the resident do when the attending is supervising the case versus when the fellow's supervising the case? Well, this is just a little bit of data from the second minute of drilling on a mastoidectomy for a cochlear implant. So for example, overall, we see that the 2s, the 3s, the 4s, and the 5s move different amounts. 2s move less than 3s, than 4s, than 5s. So if we look at the fellow supervising the case, nice relationship there. So when the attending is actually supervising the case, perhaps there's a different pattern. So perhaps the 2s and the 3s are gaining more confidence, or perhaps the attending is letting them do more than the fellow, or encouraging them to move a little bit more quickly, who knows. But for the 2s and the 3s, we actually see an increase in distance with the drill when the attending is supervising compared to the fellow, and we see the opposite, meaning the more senior residents are actually moving less when the attending is supervising than the fellow. So this is very preliminary data. This isn't necessarily all blinded. We know we're being recorded. I record everything in my room. But in terms of even how we are being supervised and what's going on, I think there's a lot that we can learn from these sorts of studies. So when we think about surgical skills and we think about subjective assessments, everybody on the video should be able to recall times that we've either heard this about ourselves or said this about a colleague or a peer, right? He has good hands or she has good hands. She has good technical skills. She's an efficient, accurate surgeon. He's really operating like a PGY3, but he's a 5. What do you mean by that? So we don't necessarily know, yet we do know. The case went well, nice job, you're progressing well. So again, we hear these things all the time, and nothing wrong with subjective evaluations. But in most of life, we have objective measures for things. And I think better application of this to what we're doing in ear surgery will be valuable. So when we think about, what's a good surgery or who's a good surgeon or what's a good training program, right? We don't necessarily have a lot of objective measures for these things. Perhaps other questions when you get out for surgery, who should be doing mastoids? Is faster better? Good question. I think faster and safe is better than slower and safe. As long as safety and outcomes and patient care and all of those other measures are also very good. So is slow a measure of incompetence? In some ways it seems to be, but in other ways it doesn't. So these are all interesting topics. So what we do again surgically, we have experienced surgeons like myself working closely with and observing trainees, and then we come up with evaluations. And we certainly do procedures on cadavers. We also have milestones and OSATs. And then, of course, quantity is important. So the ACGME has surgical minimums. We also know rough averages in terms of what your peers are doing at graduation over the years. But we have a quantity measure as well. Not necessarily doing great on objective and not necessarily doing great in a lot of areas in terms of quality. So thought we would look at this. Which surgeon's more experienced? These are just a few seconds of two different surgeons drilling. There are clues. I don't like that one. Well, I like that one. Well, that one, there's another instrument coming into the view. So the surgeon on the left-hand side of the screen, that's the first mastoid on a live person this surgeon did. The surgeon on the right side of the screen has done hundreds of ear surgeries. So what's the difference? One on the left looks pretty smooth, etc. Okay. Surgeon on the left is incapable of using his or her left hand to help him or her at this point. Well, but the water looks good and the field is clear and all that. It's true. So interesting in looking at these sorts of things. What are we looking at? So we do a lot of surgical videos, as do colleagues around the country. We use them for coaching, we use them for assessment. We are trying to objectively describe skills, and we're also trying to track progress over time. Sometimes we can do this fairly well. In terms of coaching, it's tough to coach in the operating room. So we really don't have a lot of the equipment, even that we have at home. I've got this real fancy DirecTV dish on my roof, and if I miss something, I can go back and rewatch it. I wasn't sure if that was a T or an S. I could go back and listen again and get the word correct. I think we should have this stuff in the operating room. And it's tough to disrupt surgery to go back and look at things when you're actually playing the game or operating on the patient. But perhaps those sorts of almost immediate feedback would actually be better for us as trainers and for the trainees. So many of you have been in my office looking at videos after cases. A little more challenging right now, but hopefully those are very helpful in looking at that, because you probably remember the case very well, minutes to hours after the case, and could look at it and see where you were making progress or where you were struggling in a particular part of the case. It's also possible, when these are stored well, to look at these over time, right? And, say if you drilled and found the dura, right? Well, you could watch that again and see where the problem happened, and then hopefully avoid having that happen the next time. So we've chosen a mastoidectomy because it's a key indicator. It's used for a lot of different otology cases. There's obviously a single way to do a mastoidectomy. It all has to be done exactly the same way. Everybody doing it does it the same way. There's a single vision. Everybody watching a mastoidectomy has the same view of the mastoidectomy and comes to the same conclusion of a mastoidectomy. Or perhaps they don't, because they really don't. But in doing a mastoidectomy, we've all seen the book, you drill a 7. You have to drill a 7. Everybody drills a 7. You're safe up at the top part of the 7. It's the same every way, a reverse 7 on a left, a 7 on a right, etc. Right? And then how we grade the residents is also very standard with a mastoid, right? How well you got to the tegmen and define that, how close you got to the ear canal, if you stayed out of the ear canal, et cetera, et cetera, et cetera, right? Well, it's not very standardized, even though the approach is generally fairly standardized. So, and in the olden days, it was certainly see one, do one, teach one. All right, it really wasn't like that. But a lot of surgical education has really been based on these: see a couple, do a couple, teach a couple. And especially when you're getting to the doing part and teaching part, you really have to understand this stuff pretty well to be able to do that. So in terms of mastoids, at the end of a PGY 5-year, national averages in terms of on live patients, is around 40 or 50 cases. And from a 10,000 hour standpoint, 40 to 50 cases is certainly not 10,000 hours. And we do a lot of ear surgery here. The residents do a lot of ear surgeries. They often graduate with 2 times or more national average for key indicators. Lots and lots of time. For programs who are doing under national average on live patients, that's really not a lot of ear surgery. Still may be competent, still may be meeting ACGME minimal numbers, but good to be doing more. Teaching a mastoidectomy is challenging, right? That's a very, very powerful, aggressive drill that we use, especially early in cases, and you can get into trouble. If you don't really know how to use a chainsaw, you probably shouldn't be using a chainsaw to cut down a tree either. So teaching can be a challenge, and certainly learning how to do it and getting better at doing it through training and even after training is also challenging. So how we teach, how we grade and evaluate trainees, do we agree at what we're looking at? Do we know what we're looking at? And all students and residents do not learn the same. So the standardized approach is fine, but with some variation. Let's think about medicine as an art or medicine as a science. We're going to think about artists as well. So we are surgeons. We are not artists. We are surgeons. We are not necessarily scientists either. But certainly art comes into play and science comes into play. And we're also doing things that we don't start learning how to do until we're about 26 or 27 years old at a minimum. I've taught hundreds and hundreds and hundreds of people how to play tennis. those who start at age 26 never get very good. So we are now teaching 26 and 7-year-olds and 30-year-olds and 35-year-olds how to do very fine, detailed stuff that they may not have a lot of training on growing up. And we have a duty to the public and the patients and to them to try to get them to be safe surgeons and to be competent and to have as few errors as possible. Let's talk about art for a minute. Okay, that's a very, very expensive painting. Very beautiful painting, maybe subjective. Simply drawn would not have been, would have likely been traced, etc. If there's an actual person there in the olden days, there were a lot of glasses and light and reflection onto paper and tracing over that. A lot of very good portrait artists out there, including Leonardo da Vinci, assuming that he actually painted this. Probably a lot of artists relatively can do stuff like this. But I can't do that. And then we put value on these sorts of things. Somebody paid $450 million for this. Well, we're not just creating artwork when we're doing surgery, but there's a lot of artistic thought in terms of 3D and 3 dimensions and what we're doing and what both of our hands are doing and shading and all that. That really goes into what we're doing surgically as well. And we do operate differently. So I pose this to you as surgeons. Does anybody operate like this? Right? Would this be how you view yourself as a surgeon or what you do surgically? Let's talk about something else. Modern art is different in many respects than traditional art. And for example, this particular artist may very well be a great portrait artist as well, but he didn't choose to paint like that. And the conception behind this art, I'm sure, is much different than the other one. And when you see this type of art at an art gallery, for example, National Gallery in DC has a lot of this artist's work. People will come by and look at that and say, I could do that, or my child could do that, or I could do that in kindergarten. First of all, you can't do that. That's not easy to do, and you didn't do it first, and you're not going to get paid $186 million for doing one of these particular artworks either. So as an artist, though, is this very directed and regimented and rigid, and does anybody actually think of themselves as a surgeon like this? All right? Maybe. We're all artistic in a lot of ways. How about that? Does that ring a bell? Right? That's just garbage. That's child art. That's splatter paint. Anybody can do that, right? No, you can't do that. You can't do that any more than you can do the first one or the second one. 200 million bucks for that? Well, that's the subjective part of art. Some people find that visually attractive, others don't. Same for that one, same for that one. I don't really like to look at people. Does anybody operate like that? Okay, this isn't necessarily just random splatter either. This is this particular artist's vision of what this was supposed to look like. Well, I see train tracks in there. I see a 3. I see whatever. Well, you see what you want to see in this. But think about this from an artistic standpoint as well, too. It's tough to measure this sort of stuff. How good is this? Well, it has value. Let's think about, instead of art now, let's think about sports, because sports is cool. And let's try to teach somebody how to play tennis or how to drill a mastoid starting at age 26. How to get better, how to measure improvement. Okay, is that a nice looking shot? So objectively, to get better at tennis, you need to run and hit faster. You need to be prepared earlier. You need to be more accurate, fewer errors, higher RPM on your shots. And then when it gets down to actually winning points, some points have more importance than other points, and you have to win more of them, and then obviously, hopefully, win more matches, right? So if you read Tennis Magazine or Golf Digest or these magazines, right, there's always things on the front cover, right? Hit a drive like Tiger, right? Hit a forehand like Roger. Well, unlike surgery, this stuff's actually been analyzed like crazy. So Roger's just retired. And, you know, if you can now use the word fix your forehand, right? You're not going to watch Roger and fix your forehand. You may do some improvement of your forehand, but I'm not actually sure what a fix of a forehand means or a fix of a mastoidectomy means. When we get into sports analysis, somebody's actually taken the time to do a lot of measures for these particular athletes. So I'm really focusing on the top people ever in their games. But this is Serena's forehand and looking at hand speed and racket speed. And after she hits the ball, there's a big drop off in speed, and then it picks back up as they go forward. Okay. Let's look at Rafa. So somebody's then showed what his racket does, right? It's super high speed camera, what's the ball doing, etc. Okay, do not try this at home. You will hurt yourself. Okay, well, I can do that or I can do that. You can't do that. You can't do that any more than you can paint like Pollock or paint like Rothko or paint like Leonardo. But you can analyze this and you can work really, really hard and you can hope to get a little bit better at this, right? The folks that I'm comparing us to as surgeons are some of the greats in their particular fields. And again, tennis and analysis, maybe this is things we should be doing in surgery as well too. I, as a professional, get paid for what I'm doing, and I'd like to get better at what I do. Maybe faster, but I'd like to get more accurate. I'd like to have better results. I'd like to be safer. I'd like to teach you guys to get better and safer as well too, which we do, but can we improve at that? So we do labs and we do courses and we talk about how we do in the OR and progress through cases. And we say things like, let me show you this, or let me sit for a couple of minutes. And sometimes we do measures in lab. How much have you done in an hour? Sometimes some training happens and then we measure again. How much more is done, or are there fewer errors? There's more and more simulation coming within otolaryngology. You can do 3D goggles and haptic feedback and all that. We have a computer on the floor that we were doing some research with Ohio State group with a haptic drill and 3D goggles. All pretty cool and helpful. But a lot of our teaching does happen during the game, during the actual time where bleeding matters and patient safety matters and not making mistakes matter. And we are actually measuring what is being done during that particular time. And with this research, we're actually asking questions like, what's the level of the surgeon? Or is that surgeon competent? Or how many inches are you moving per minute, or what's your left hand doing, what's your right hand doing? And then we're also trying to figure out what correlates between competency and level of surgeon and then various counts on things. So we're hoping to continue to improve how we measure surgical instrumentation during these live cases and identify objective metrics that correlate with resident experience. So we're going to go over a couple of things and just give you guys a little bit of data for what we've done. First one's going to be a retrospective review of surgical videos, 1-minute videos by residents during the second minute of continuous drilling with a cochlear implant. We have some PGY 2s, 3s, 4s, and 5s. Lots of 5s, less junior residents. Kenobi is the software we are using. We are developing our own software and using some AI, getting some help with the team at Clemson. But Kenobi is a nice product that we've used for this, and you can measure things like distance traveled or speed or acceleration. Some of these measures are hard because acceleration over a minute, you have acceleration to the left and deceleration, acceleration to the right and deceleration. Some of these are very challenging things to use. For example, if we look at the mean drill motion for resonance in the different classes. So we do see growth over every year, but the statistical significance, we only found a difference in comparing PGY2s through PGY5s. This is how many centimeters were covered in a minute of drilling. If you look at resonance individually over time, we do have some resonance that we are able to look at them in multiple points of time, a 2 to a 3 or a 2 to a 4 to a 5, etc. So as you might expect, you get faster at things or you travel more distance per unit time as you get more advanced. Makes sense. These are some of the things that we're talking about when we talk about you're making progress, etc. For example, if you look at C down there, the yellow one versus E, maybe E has good hands and C doesn't. This is the subjective measures that we're really trying to get a better handle on also. Suction irrigator. So the non-dominant hand in a lot of surgical procedures actually correlates with trainee advancement or trainee skill level or trainee experience more so than what the dominant hand does. And this is a bit challenging for ear surgery depending on where you are in that second minute, if you're trying to thin the canal versus just on the mastoid versus where you are. But for example, we did see some progress in terms of the distance traveled as well in a minute of time, where the senior residents actually traveled further distances than the junior residents. Not sure why it's a little less in the chief at this particular one, but again, it's a limited sample. So that's just a graphical measure of the two right there that you do see suction ear. This is a slightly different group, but you do see distance traveled by the instrument and by the non-dominant hand increase over time. And to cover another project that we did. So these are, again, videos during the second minute of drilling. And we actually asked survey questions. And we asked survey questions that were yes, no, or Likert scale. And we also had participants count the movements, like how many strokes per minute, how much time, what's the percentage of time the suction was moving, did the surgeon use the cutting edge of the drill, etc. We're not going to show all of that. There's a lot of detail in there. But for example, let's look at a video. So first of all, it's a left-handed surgeon. Very smooth, drills on the bone quite a bit. This is a resonant. Resonance just kind of in the mastoid, not necessarily defining much. Left hand's dominant hand, right hand's non-dominant hand. Doesn't really have all the coordination. Well, what's he talking about? Well, that's exactly what I'm talking about. So hard to measure this sort of stuff. So a lot of times you get subjective measures. Case went well. That's just the pattern of what the drill's doing for that particular surgeon. Let's watch another one. Another lefty. Don't have too many lefties. Sometimes you can figure out who the surgeon is, which is not the point of all of this. If you turn these around and run them backwards so they look right-handed, the drill's spinning in the other direction, so it looks funny. So, left hand's making a lot more moves than the other one. Right hand's trying to provide the right amount of irrigation, struggling with that. That may not be the surgeon. That may be whoever's helping the surgeon. Certainly moving a lot more than the first case. Okay, seems a little bit scattered. What's he talking about? Case went well. That's that surgeon's pattern. Okay. So same speed. This is not sped up. Distance traveled is a lot more than the other two. Left hand's working a lot more independently than the other one. Surgeon's also way further in the case than the other two. Okay, so when you look at things like that, a little more objectively, perhaps, you would perhaps estimate this surgeon's done a lot more than the other two surgeons. Okay. Boy, I don't like that. I don't like what that left hand's doing. It's all over the place. Well, if the left hand's able to work independently of the right hand, Neil Peart, if Leo's paying attention, maybe this particular drummer or this particular surgeon's able to get more done per unit time. Pattern for that surgeon's going to look a lot different. And if we just look at those three, junior, senior, and attending. So the distance traveled by the attending compared to the junior residents about 3 times as much. And the head motion is moving a lot more. So the surgeon here is pushing on the head a lot more, making the head move around a lot more. Probably pushing a lot harder, probably removing a lot more bone. If we look at the suction irrigator is also moving around quite a bit more. And I will bet that this particular suction irrigator, a fair amount of the motion was missed because it was off the screen. Okay, so those 3 examples subjectively are much different, and objectively, when you look at some of these particular measures here, how far the instruments travel, you can see a significant difference. If you look at the number of strokes, right? Well, what's a stroke? Going one way or back and forth or whatever? Well, a stroke is a stroke. And that's also not necessarily completely an objective measure either. But the more senior surgeon here is obviously doing a lot more than the other surgeons in there, which should be expected. So the difference between the attending and the senior, perfectly fine. But I think the real important measure is between a junior resident, which was, I believe, a 2, and a senior resident is a 5. You can see a tremendous amount of progress in some of these objective measures. If we look at surveys, the questions that we asked otolaryngologists, we found statistically significant correlations between certain things, like the use of the drill tip and the use of the suction and the use of the irrigation and strokes per minute, estimated drill speed. We even asked questions like, do you think the surgeon's drilling too aggressively or too lightly? And the respondents weren't really great at answering a lot of those particular survey questions, but we do find some correlations between the objective measures and some of the subjective questions that we answered. If you look at how residents respond to these sorts of questions versus attendings, responses are actually quite different. So that gets to some of the point of, do we really know what we're looking at this point? If we look at the objective measures, the last point up there, they do positively correlate with the level of the experience or training of the surgeon. Now, a very controlled experiment. We just had 3 videos to look at. So we actually then looked at a whole bunch of shorter videos. So we thought about this in terms of, I don't necessarily need to watch Tiger Woods play an entire match, a golf match or golf round. We should probably be able to look at Tiger Woods hitting a golf ball, or me looking at it hitting a golf ball, and knowing that there are significant differences between the 2 golfers. I've never had a golf lesson. So comparing a senior surgeon or an attending surgeon to a resident who's never drilled on a live human, you ought to actually be able to see those sorts of differences as well. So, so this is a survey that we sent out to otolaryngologists again. And we actually had 12 5-second videos of mastoidectomies by junior residents, senior residents, or attendings, again, during that second minute of drilling. And we asked the people taking a survey to estimate the level of experience of the surgeon and then rate the competency of the surgeon. Short. In terms of the survey, probably about 50 reviewers answered the survey. There's a lot of variation. So the average responses make sense. So crowds can generally give a decent average to the particular question. But specific responses to specific videos or specific levels is actually quite challenging. And maybe that's because the videos are too short. But we didn't do all that well getting surveys for long videos, so that's why we thought a short video survey would be a good start. When we asked about competency, so the question is, what drives responses to higher numbers, more attending-like? So would it be the speed? Would it be the distance traveled? Would it be correlation between the two hands? Would it be how the surgeon is operating, right? How artistic does that jibe with what you're doing yourself as a surgeon? Is it visually pleasing, right? What are we actually looking at? When we're evaluating trainees during what we do in the clinic, on the rounds, in terms of the other core competencies like professionalism, et cetera, we as faculty are supposed to have a common vision. I don't think we do in general, and I really don't think we do in terms of when we're looking at these sorts of things. I think we have much work to do. We looked at the 3 longer videos and the 12 shorter videos using the Canovia. And I showed you the objective measures for the longer videos. I'm going to show you the objective measures for the shorter videos as well. Here's a short video. Oh, it looks smooth, visually pleasing. I like that. Leonardo da Vinci, maybe. You know, very smooth, looks very safe, etc. All right, what's the left hand doing? Absolutely nothing. Yeah, but that's how I operate. I just like to keep my left hand there, and I have the field with a nice amount of fluid, etc. That's great. What you don't see in this particular video is about 30 seconds later, the sigmoid's right here. Not into the sigmoid and not bleeding, but exposing the sigmoid. So this is a junior resident first ear case on a live person. Well, why don't you have him outline the tegmen and do the canal, which is up here, etc. Well, at some point you start. So this particular surgeon in 5 seconds went 13 centimeters. The head didn't move very much. The suction irrigator moved 1.2 centimeters. There were 16 strokes in 5 seconds. Not bad. Surgeon was deemed a 1.6 in terms of surgeon level. 1 being junior, 2 being senior, 3 being attending, and was given a competency measure just on a 0 to 100 scale of 40. I don't know what that means, but we just asked that question. Here's another short one. We've seen this particular surgeon already also. You guys know this is a senior level surgeon. So the drill distance was 25 centimeters, so I compared to 13. The head moved a lot more, 0.6 to 2.1 centimeters. The suction irrigator also moved a lot more, and 35 strokes were counted during that time period. with a stroke length of 0.7 centimeters, etc. Surgeon level was deemed 1.7 or 1.57, the same as the first surgeon, first case, and the competency was actually deemed less. So maybe 5 seconds is not a reasonable amount of time to actually deem somebody as competent or not. But these are challenging sorts of things. You don't need 5 seconds to look at Tiger hit a ball versus me to deem competency, or maybe one of the greatest ever versus a complete novice, right? Okay. So Josh, what's the difference between this one and the other two?
Making fewer, longer, and more intentional strokes.
How about bone removal?
A lot more bone is being removed.
Is this person used to being videotaped?
Are they used to being videotaped? Maybe.
Could impact what they do, right?
Mm-hmm.
Is this a reasonable mastoid or a dense mastoid?
It doesn't look particularly well aerated from.
Doesn't look all well aerated, right? So again, these are things that are hard and challenging with these particular videos. Okay, this particular surgeon's in attending, quite experienced, kind of doing a follow the leader sort of thing. Grind, suction, grind, suction, grind, suction. 14 centimeters, okay, as much as the resident doing his or her first case. Head wasn't moving all that much. Suction irrigator moved about as much as the drill, 6 strokes, okay? The particular group who was being surveyed liked what this looked like, okay? Thought that this person looked experienced and fairly competent during a 5-second video. You guys have seen this one. Okay. Drumming differently than the first one. So Josh, tell us a couple of differences between this one and the last one.
Well, the mastoid is much more anatomically favorable. They're huge air cells, very well aerated. The surgeon's making more shorter strokes that are removing less bone with each stroke. The left hand is moving all over the place.
Okay, good. So again, when we're analyzing this ourselves or for others or helping to train people, right, trying to figure out what they're doing and what we're seeing, okay? So 40 centimeters during that time. Head distance moved a lot. Suction irrigator moved more than the drill. Number of strokes, 47. Way different, right? Average stroke length, 0.9 centimeters. Average stroke length there, 2 centimeters, okay? So we're not weighing bone removal or anything like that, but much different, okay? And visually pleasing or not, surgeon operating differently, okay? So in terms of just asking somebody, where would you put this particular example in terms of surgeon level or competency, much different than the particular last example, okay? So, and again, how we're doing this and how we're figuring things out, and is this person used to being videotaped, or were you trying to make a point because it was for an experiment, etc. Challenging. If we look at the averages for all the 5-second videos, not just those 3, but all 12, the juniors won about 12 centimeters. The head moved about 1 centimeter. Suction irrigator moved about 7. The seniors did more than the juniors, certainly, and the attendings did a lot more. Okay, so again, you should see progress over time, and we can actually measure that. If we look at these two just side-by-side comparison, vastly different, and Josh explained the differences between the two very well. So again, Josh is now a senior surgeon, would be a junior attending if weren't doing fellowship. And his job is to also help us train residents become better surgeons. So trying to figure out what you're seeing, trying to make sense out of it, trying to get the particular surgeon through the case safely, not causing problems in a reasonable manner, part of the duties that go along with being a fellow. So that's all early work. So we've actually started looking more, we started looking later in the mastoid. So at some point, the first 2 minutes of a mastoid isn't necessarily all that interesting, but we really don't understand that all that well at this point. We're not at the point where we have artificial intelligence being able to measure all this stuff without any input. We're getting there, but we're not quite there. So we've actually started looking at later in the mastoid. So we looked 5 minutes in rather than 2 minutes in. There's obviously a lot of variation how far people get in 5 minutes. So that's not as standardized. You certainly are seeing significant differences between juniors and seniors in terms of how far they are, etc. We are generally still using a 6 millimeter ball at that point. But in terms of distances, we're not seeing that much differences between the residents at this point, 5 minutes into a mastoid. We are finding major differences in terms of what the fellow's doing and what the trainees are doing. Down in the antrum is a tight area. And if you operate with me, often you are still using a 6 millimeter cutting burr. And you need to be careful down in through there. So we don't expect people going quickly. We don't want to expose facial nerve or hit the incus or the horizontal canal or the tegmen. And we have yet to find any differences in terms of resident, junior or senior versus fellow down at the antrum. I don't think we have any videos of the attending at the antrum at this point. We're looking at the early facial recess, and we are seeing major differences between the attending and what the trainee is doing just in terms of distance right now. Early in the facial recess and then later in the facial recess. And I have no doubt that there are a lot of differences in terms of what the trainees are doing, in terms of how much you're pushing or the exposure or some things that we're yet to be able to measure, but we're just not finding them yet. So we are starting to find some interesting things further in the cases, but we have a lot more to go. And we're hoping that by the time we get better at figuring out some of these differences further in the mastoid and in the facial recess part of the case, maybe even drilling the niche off the round window. That would be a cool thing if we can measure that, that we have our artificial intelligence and our computer vision work much further advanced because this is painstaking to generate the data off of these videos. So just a couple more slides. So can we improve? And by we, I mean us as teachers as much as trainees. So teachers, I think, need improving what we're looking at, objective measures, not necessarily just good case, but what do you mean that was too close, or what do you mean I need better light down there, or what do you mean get my hands out of the way? What do you mean slow down? What do you mean go faster? I think there's a lot of improvement that we can do. Trainees can obviously get better, and that's our job. That's our duty. That's our duty to you guys to get you better at doing this stuff. And hopefully we can get better faster. And better is not necessarily just being faster. It's safer. It's getting better light down there so you can move along in the case. You can do more of the case. You don't have to have the person coming in behind you clean up your approach because you're trying to get too far into the case before being ready to get that far into the case. We're hoping that all of this leads to better surgery, better outcomes, better results as we move to the future. And this is what we're working on. So we are looking to do more automated video analysis to count strokes and determine density of data points at various points of a mastoidectomy. 3D would be nice. 2D is hard enough. If we can get better at 2D, maybe we can figure out some of the 3D. We hope to get better subjective measures as well. I hope to get a better common understanding of what it means to have good hands, or, you know, what are you talking about when so-and-so's a PGY3? Um, we hope that residents get better at seeing what they're doing themselves and can learn from that as well too. So hopefully we will get a video recorder in the operating room that we could actually spend a couple of minutes going back in time and see, here, see what you did right there. That looked great. Or let's keep working on this so we can get you further in on the next one, or just further in on this one, for example. Perhaps even someday these measures could be used as part of ACGME training and evaluation of residents. So we evaluate you guys. We use eValue, now MedHub, to evaluate you guys. We have a bunch of questions that we have developed to help us give slightly more objective measures than subjective, but I'd like to see some objective measures as well too. Again, you don't need to be doing X amount of centimeters per second to be a great surgeon. But for example, if you're not progressing in terms of removing this much bone or this much bone per unit time, or just moving this appropriately, gives you opportunity as a trainee to work on things in the lab, or maybe specifically work on specific aspects of a case in the operating room as well. Making progress, long way to go. Those are some resources. That's all I got.
All right. Thanks so much, Dr. Meyer. We'll open it up to questions. I have a couple myself. Kind of jumping off the last point you were making about what kind of has to be, what should be done the same between trainees versus where is there room for some variability, like not everyone has to drill this much pressure or this exact speed, but you need to remove a certain amount of bone by a certain time. You know, I'm curious, like how you think about individual differences in terms of trainee learning styles when the measurements that you're trying to have people match are usually an attending doing something, and the attending is doing it well, meaning the surgery is completed, the patient doesn't have complications, but then you're trying to get trainees with maybe several different learning styles to match what the attending is doing. And how do you think about what things that the trainee is doing that need to be exactly the same as the attending is doing, versus what things can there be variability as long as they're getting to the point where you want them to get to, if that makes sense?
Yeah, I mean, I think that's a doing question, but I think that's an education question as well. All right, for tennis, for example, the racket has to be plus or minus, right, a fraction of a degree, whatever, when you hit the ball for this to occur, right? Now you can do slice or topspin or flat or inside out or whatever, right? But at some point, the hand has to get to a certain position, so the racket or the club or whatever is about where it needs to be for that to happen. And what we're doing is not high velocity impact, like hitting a ball, right? It's much more fluid. It's what we're doing. Maybe it's more akin to jogging or a sprint or a whatever versus just impacting a ball. So, perhaps tennis or golf or something like that is different. Shooting a free throw, for example, right? I mean, you can shoot free throw underhand and perhaps be very good. Rick Barry is an example of an underhand free throw shooter, one of the best of all time, right? At some point, right, the hands left the ball at plus or minus a fraction of a millimeter, probably time and time again. So, there are things that get measured a lot, that make a difference. Tiger Woods, for example, when he was at his peak, right, 99% of the time, right, the club face was within a fraction of a millimeter and a fraction of a degree every time he hit the ball. So, the ball would actually go where he wanted it to go. So, those sort of sports things really get measured a lot in terms of jogging, running, cycling, those sorts of things as well. We do have measures of that. I'm just not as familiar with those particular sports, and those probably matter. How we push. My leg's different than your leg. My seat angle needs to be different. The pedal angle needs to be different. For a resident who is in the 5 foot tall range, with our particular group here, we have one or two, and she in particular can't sit the way I sit. We can't hold the drill exactly the same. Our pressure points are going to be different. The angles have to be different. So, this is a comfort as well too. I just operated at the VA today on a big scope. And that particular scope is actually too large for a couple of our residents to really sit very comfortable at and get around and maneuver all of this, right? So it's very challenging. And, the exact angle of the hands doesn't need to be exactly the same. But for example, we were just doing a case a couple of weeks ago, and the resident's hand was a lot like this when it really needed to be like this. So the resident could see that. I could sit for a minute and say, hey, if you do this, you can remove more bone this way and probably cause less problems up there. And for example, later in the case, we were doing a facial recess where it was imperative that the drill was floating in midair, not sitting back on the nerve, heating the nerve up. So that was a nice example for the particular resident of the vertical holding of the drill, which wasn't working all that well back in the mastoid for you, can then work well in the facial recess. And again, sometimes it's trial and error experience, or watch somebody else do that. Are you really seeing what I'm doing that point in time? It's very complicated.
And I guess another thing I was wondering was with regards to kind of using PGY level as like a proxy for experience. Like, do you think in some ways that could be problematic in terms of lending itself to bias? Because if you say that PGY 5s are good, and then we measure versus PGY 2s are presumably worse, and then these are the measurements that are good versus worse, then it's sort of like a self-fulfilling prophecy, or it could be, because what if the PGY 5s, all four of them in the hypothetical scenario, are dangerous surgeons, and the PGY 2s are savants, and then you kind of I don't think this is really going to happen, because that typically is not the case, but is there a risk of therefore saying these movements are good surgeon moves when in fact they lead to bad outcomes?
Yeah, that's a great point, Josh. So when we're analyzing these videos, that's blinded. So we don't know the level of the particular surgeon. When we're asking survey questions, we don't know the level of the surgeon. And this really doesn't have much to do about the individual surgeon, except when we are teaching that individual surgeon, right? Or come back in the office and let's review that. But yeah, absolutely. And clearly you're not talking about this year's PGY 5 class. They're all fantastic surgeons. But you do see differences, and you do see differences sometimes year to year. You certainly see differences individual to individual within classes and across classes. And yeah, 2 versus 5 is a level of experience. You may have a 2 who's drilled as many mastoids as a 4, for example, or has been in a lab, and You know, there's been at least one particular study out there that's actually measured, asked trainees how many bones they've drilled on live patients. You can get that from ACGME, or how much time they spent in a lab, or how many lab bones that they've drilled. And you know, how much that actually correlates, that amount of numerical experience correlates with competency is interesting. Yeah, it's challenging. So we've been asked to, can you just see how many surgery mastoids they've done at the time of that particular surgery? You can actually do that. You can pull off the ACGME site from day one up to the date of that surgery, and you can get the number of mastoids that they've done or that they've counted, right? But even, for example, with that, well, I did 51% of that case, so I could count myself as primary surgeon, whereas somebody else doing maybe 49% isn't going to count themselves as primary surgeon. So it's very challenging. And we certainly have trainees, our group included, who learn differently and who want to be taught differently. And that's from lectures or didactics through what we do in the operating room. Yeah. Not easy to train us to do what we do. We all kind of do the same thing. We all kind of want to get further in the case than we're ready to get further in the case. And then the senior resident, fellow, or attending often has to come back and do some of the other stuff to be able to allow you to get into the more important parts of the case. I know that happened when I was a trainee. I know that happened when I was a fellow training residents, and I certainly know that as an attending now, training fellows and residents. So we do have a lot of common traits.
Thank you very much. I'll hold on a second or two in case anyone else wants to ask a question, and otherwise we'll finish up since it's 6:10.
It's quiet.
All right. Well, thank you so much, Dr. Meyer. Really appreciate the talk. It was very interesting and informative, and look forward to seeing everyone next time.
Have a good night, everybody.